Hello, welcome. My name is Rachel Cubby-Adler, and I am on the Force staff. I am the social media and communications manager. Really excited to see you all here, and I was excited to come to this session, so I'm very glad that I get to also moderate it. It's like a double win. I think you all have been to enough of the sessions that you know we really would love for you to fill out a survey and evaluation when you're done, and it really does help us, and people actually do read them and respond and get the feedback. So, and particularly an overall of the conference, since we're nearing the end, if there were things that really you loved or didn't love, please let us know so that this can inform where we go from here. I have the pleasure of introducing Greg Garber. He is a licensed clinical social worker and the administrative director of the Division of Supportive Oncology at the Sidney Kimmel Cancer Center at Jefferson Health, which I've learned is in this beautiful city. That's awesome. In that role, he manages all patient-facing programs and services, including a patient education and support programming, clinical nutrition support, social work services, and numerous initiatives to better understand and address cancer disparities as they relate to health literacy, digital literacy, access, transportation, cancer screening, and prevention. Greg has lectured and taught on local, regional, and national levels on issues related to psychosocial aspects of cancer care, and have presented at numerous national conferences, including ASCO, APOS, AOSW, and APHA. Greg is engaged in ongoing research related to delivery of supportive medicine and survivorship programming, shared decision-making, digital and health literacy, medical marijuana in oncology populations, and lung cancer screening in underserved populations. Greg has extensive experience implementing supportive services for patients with cancer through their care trajectory. Greg has a private psychotherapy practice for the past 25 years where he sees patients and families coping with a cancer diagnosis or a genetic predisposition to cancer. Additionally, Greg co-directs the SKCC's Patient and Family Advisory Council. So without further ado, and thank you so much.
Thanks so much. Thank you. That's a lot. I get paid for one of those jobs, though. No, I'm not sure which one. But I've been doing this for a while, and who would have thought at 57 years old that I'm sitting up here talking about cannabinoids. As a teenager back in where I grew up, with little bags of God only knows what was people were putting in them, and now we're sitting here having a conference talk, many conference talks, a number of very large federal grants that we are fortunate recipients of, looking at various aspects of cannabis as it relates to cancer care, as it relates to pain management, symptom management. Our most recent grant is looking at the interplay of cannabinoids and immunotherapies. And so this is not a cannabis or any other integrative approaches is a panacea. We're certainly not evangelical about this. I have to say my colleague Brooke Worcester, who was giving this same talk at another conference today, we have worked together on building Jefferson's cannabinoid program for a number of years now and have seen about 4,700 patients, many of whom we follow longitudinally, looking at kind of how people are using cannabinoids in their cancer care and symptom management. I wish I could tell you that we had a ton of research on all of this. A fair amount of what we learn is anecdotal. There are a number of reasons why there isn't a lot of research in our country. The main one being that cannabis is a Schedule I drug, which some of you may know, which puts it in the category of drugs like heroin and LSD and other things that are considered to have no medical use. It has a long and sordid political and social justice history, and it's been kicked around a lot, but end of the day, I think we're moving past that. It will be rescheduled within the next, I don't know, I want to say 6 months probably, to a Schedule III drug, which will make it much easier to research and will change a lot of the kind of financial aspects. Please stop me and interrupt me. I appreciate that. I'm going to kind of go over some stuff stuff that I think is interesting, stuff that you may think is interesting, stop me, ask questions. It's an exhaustive topic about which there's not a lot of information. And so if anything, I would hope that folks will come out of here with some basic understanding of kind of where things are right now, not just in terms of using cannabinoids or melatonin or CBD, which is a cannabinoid, for symptom management and other things, but just kind of, some of the good and the bad, for lack of a better way of saying that. I do get some consulting fees, none of which are influencing anything that I am saying today. I think we're influencing them because we have this huge patient population that we have seen, but just want to say that. And social workers never get big consulting fees, so it's like I am not a shill. I am not owned by anybody. Although I'm willing to be, I'm just not. Anyway. So big picture, we're going to talk about just cannabis in the endocannabinoid system. Anyone know that a runner's high is actually thought to be more part of a native and an endogenous system in our bodies that produce natural cannabinoids that make us feel more relaxed and calm us down? Interesting stuff. Some risks and benefits, some evidence. We're going to talk a little bit about CBD and melatonin and other supplements, and kind of what's next. So because we have a sense of kind of where things are going. So many people, I'm not assuming everyone has had a cancer diagnosis. I know some people have risks, have family members or caregivers, but everyone pretty much has some side effects of something in their lives for which cannabis might be an option. We know that insomnia is a huge problem. We know we're all anxious. We're even more anxious now. So like human condition stuff. And we know that in our experience and based on kind of basic research that cannabinoids and other compounds that we're talking about today often play very nicely in the sandbox with prescription medications. While there are some contraindications, and we are careful about that, largely these are not things for which there are very significant drug-drug interactions. And the ones that are there, we are aware of. All right, so let me get a little geography here. Who lives in Pennsylvania? Okay. Who lives in the middle part of the country? Okay. And who lives on the west? Wow, we have a really geographically represented group here. That's fantastic. Anybody live in a state that has no cannabis program at all? Okay, couple. All right. Those 3 states there in gray, it's not happening. They're just... It's just not. The dark green states are states where there are adult use programs and there are medical programs. This map can be found online also, and I will give you all my slides. Please use them, take them, share them. This is just, my goal is for people to just know more and understand more. I'm not wedded to, any materials. And so I think it's just important. Each one of these states that is in green has a different program. Because cannabis is federally illegal still, the federal government a number of years ago said, listen, we're not going to enforce that. We're going to turn a blind eye. You guys go do what you want, which is fine. Not a great way to do policy, but it was a way. California kind of led the charge years ago in the beginning of the AIDS and HIV epidemic, and it has kind of spread eastward. Each state here is its own program. And so if there is a product that you buy at a dispensary in New York, and you want to get that same product at a dispensary in California, those products have to be manufactured completely separately. So California needs to grow, produce, and sell products that are made in that state, and New York has to do the ones in their state. So there's like no economy there. It's just kind of ridiculous. It creates a lot of cost and redundancy, and it's unfortunate. However, like federal legalization may make a difference in that. The light green states are states that have mainly CBD programs. So back in 2015, 16, the federal government passed something called the Farm Bill, which enabled the growth and production of hemp-based products. And that's why you've seen the proliferation of CBD in gas stations and supermarkets and, everywhere. And so those states it's mainly referring to that. There are issues with that. We can talk about that later. So just to level set a little bit, medical states, you need to be certified by a medical provider. And so there are, I don't know how many, there's a lot of medical states now. Some all allow doctors or DOs to do it. Some allow nurse practitioners, pharmacists, PAs. Some need you to go through an extensive online process. In Virginia, you need a doctor's note. In Virginia, your doctor needs to say to you, so-and-so is appropriate for medical cannabis. You take this written thing into the dispensary and they register you in the program. It's actually a good idea. Pennsylvania's is a little more complicated. You register yourself online, you see a doctor, they put a certification in there, you get a card. Adult use is just you need to be 21 or over. So if you drove over to New Jersey right now, which is a medical and adult use state, in 20 minutes you could be in a dispensary, show your license, and buy marijuana, cannabis. So people say, well, why do we want to keep adult medical programs if everything kind of ultimately goes adult use? Taxes. The taxes on adult use cannabis are high, like up to 35%. And so unless you have an extra 35% to add onto everything that you buy, it still will make sense to have medical certification in places. It's like liquor or cigarettes or other things that have an excise tax. Questions, comments, anybody? Yeah.
I live in Colorado, so anyway, I was wondering, if you get a medical license, can that affect, I'm always afraid that it's going to affect jobs or other things.
Yeah. I'm going to repeat the question because we're recording this, and so I'll try to be good about bringing the mic back. That's a great question. The question is, how does this affect employment and other issues if you are living in a state that has, or in a state that doesn't have legalized cannabis? And quite honestly, unless you work for the federal government or a transportation, like whatever your public transportation is, or airlines and other trains and things like that, by and large, we have not seen out of these patients to whom we've spoken a single instance of where this has affected their employment. Theoretically, it could. Commercial driver's licenses are incompatible with cannabis use because they are drug tested. However, for somebody going through treatment who suspends that license for a period of time, they can do that and then go back, get tested at the end, and get that license back. That was an issue early on, but we haven't seen it. The interesting thing, it's hard to determine where, how, who. Many employers are no longer testing for this in states where it is legal. It just creates a real hassle, right? Because cannabis, when you're using cannabinoids, they stay in your system upwards of 30 days. In your urine. If you test somebody's hair, it's even longer. Everybody tests positive. And so, you chase that down. Just to give an example, at Jefferson, where I work, which is a big academic medical center with a big comprehensive cancer center, don't come to work impaired. That's the acid test. If you come to work, you're not impaired and you're doing your job and you're not harming anyone, that's pretty much the test. We do not test for cannabis anymore. Yeah. Let me bring you back.
Hi, I'm from New York. I also have the medical marijuana certification in New York. I was just signed up to volunteer. I went back to where I was treated for cancer, in New York, and one of the tests they did, they had me slide my urine sample through like a box in the wall from the bathroom, and then the nurse, but I said, you know, the marijuana is going to show up. And I gave them copies of my license, but then someone called me from the FBI saying, like, I said, but it's legal. I said, you can't, and I'm only volunteering, I'm not getting paid. I didn't understand. Like, there has to be, with the New York State Department of Health, first of all, finding someone who has the medical marijuana certification is hard to find. Then it's not regulated, so some doctors do it kind of a sneaky way. They'll bring you in, and then say you have to come back, and they only get, you know what I mean? Like, they collect more fees with more office visits, the copays, or whatever.
Yes.
And that's disappointing. And then the oncologist usually only will give you the medical marijuana certification if you're like stage 4 and you've lost your appetite. They should offer it to all of the cancer patients, because that's the only thing that takes off the edge for me. But I do it at home and with a gel cap, but like literally you driving around, you can get high now with the recreational. So like that affects your coordination and balance, and that's a weapon, your car, when you're driving around impaired like that. So there's a lot of issues here.
Yeah, you brought up a whole dissertation's worth of information there. No, but those are incredibly astute observations. Yes, those are all potentially true things. This is just not regulated enough. And you could just walk into, you know, New York's the Wild West right now with people just building dispensaries and opening them and the city not enforcing it, right? Which is hysterical. I was at a meeting at Memorial Sloan Kettering a couple weeks ago, and in Midtown, like every fourth store is an illegal cannabis store. So there are no hard and fast rules on any of this. A couple of things. One is the system has largely evolved in a lot of places to not make people have healthcare disparities have been paid attention to in a lot of states. Like in Pennsylvania, they no longer charge for the card. Doctors who can certify for anywhere between 3 months and a year are almost always doing 1-year certifications. In the beginning, they were making people recertify every 3 months and charging them out of pocket for that. Lots and lots of social equity issues here. We tell people that to disclose it to their employer if they're going back. Bring your card, show them. Honestly, we have not seen somebody get hassled for that in Pennsylvania. And Pennsylvania, you know, is a little bit of a purple state, but we haven't seen it. But again, there are a million different experiences, and everything you bring up is valid. I'm happy to go down that rabbit hole with you if you would like. We've written papers on that. Just who knows the difference between hemp and marijuana? Okay, about a quarter of people. All right. Hemp is they're the same plant, basically. Hemp is bred to produce very, very low amounts of THC. Anything below 0.3% THC is hemp. Hemp can be used for lots of things, building materials and clothing and cosmetics and CBD that you can ingest, you can rub on, you can vaporize, you can put in food. Anything with more than 0.3% of THC, which is the intoxicating compound, is marijuana. An interesting twist has happened, however. People may be seeing advertisements for Delta-9 THC that can be mailed, right? And so right now, if you can't mail order marijuana from a dispensary. It's illegal, it's interstate commerce, you're going from one state to another, they don't want that. However, with the Farm Bill, people have learned how to extract higher amounts of THC out of hemp. So, which is legal right now. There's some legislation that may make that illegal. So you actually can buy THC products, mail order in most states, not all states, most states, that have a decent amount of THC. For a novice user, somewhere between 2.5 milligrams and 5 milligrams of THC is usually what will, you know, be okay and comfortable for most people. And that is actually available mail order right now. Don't know where that's going to go, but kind of an interesting development over the past period of time. There are also all these other things that I just want to kind of say. There's CBD shops that have proliferated, right? These are not dispensaries. They're just like vitamin shops. Where you can get CBD, there's a product called Kratom, which is made from an evergreen tree. It's dangerous. Just stay away from things like that. Delta 8 THC is another cannabinoid in the plant. It is intoxicating. But when you go into a store and you buy it, you have no idea what you are getting. It is safe if it is just Delta 8 THC, but you have to be very careful going into. This is just a map of our local area, and these red dots are CBD stores. And often people are confused that, it's not uncommon for a patient to come in and say, I went to a store and I got some of this. And we're like, or I went to a dispensary and I got some of this. I'm like, where was the dispensary? We're like, oh, it was in, Lafayette Hill or something. We're like, there are no dispensaries in Lafayette Hill. And so there's a lot of education that needs to happen. For today, cannabis is a plant. There are hundreds of chemicals and compounds in it, cannabinoids. We know very little about any of them, really. The ones that we probably know the most about are delta-9 tetrahydrocannabinol, or THC, which is the intoxicating molecule, and cannabidiol, which is a non-intoxicating cannabinoid. Back in the 80s, the maximum amount of THC that you would get, was in a product was usually about 5%. You can get things upwards of 40% now. So the potency of things has gone up dramatically. For anybody, I'm old, but for anybody who used any kind of weed back in the 80s and went back and tried it now, that's a very different experience. It's a very different experience. And so we have to be careful, right? Like there's risk. You can fall, you can get paranoid, you can really feel awful. It's just can be highly unpleasant. I'm sorry, go ahead.
Thank you. I was just hoping you could clarify what's the difference between the Delta 8 and the Delta 9, please?
Nothing. There's something kind of on a molecular level. They're both intoxicating cannabinoids. Delta 8 is just another compound in the marijuana plant that they have found that is intoxicating. They're very similar, and they both kind of get metabolized the same way, and so you wouldn't be able to tell the difference. The problem is Delta 9 is regulated through dispensaries. Delta 8 is not, and so you do not know what you are getting, but you will see a lot. However, if you know a reliable source and somebody who's doing that, like, okay. This is just a quick map of non-psychoactive and psychoactive cannabinoids, some more so than others. And you may see products out there, you may see products out there that kind of advertise high amounts of this or high amounts of that. We don't know. Like some people say CBN is great for sleep. Well, the amount of CBN that you need to sleep is much more than you are getting in a product that is labeled CBN. And so just to put that out there, go ahead.
That's what I was going to ask you about, the CBN to help with sleep rather than melatonin. But any of those synthetically made in the lab components that they advertise and they throw into it, are they safe or unsafe?
So if you're buying products in a dispensary, they should not be throwing lab manufactured things in. What they may do is they'll extract higher amounts of CBN from the plant. Everything that's sold in a licensed dispensary is derived from a plant. Nothing is made in a lab. So you can extract certain cannabinoids and terpenes at higher levels and add them in, which they do, and they disclose that. And some people swear by CBN for sleep. If you take some CBD, THC, and it has some CBN in it, you're probably going to get sleepy. Whether the CBN is making you sleepy, I don't know. We don't have any good studies on that. We will, though. There was an interesting study, THCV, this on the bottom right here, is a mildly psychoactive compound, and there was just a decently done study, small, that looked at weight loss with THCV. Nobody thinks about using cannabis for weight loss, right? That's not, cannabis is like, you're in a 7-Eleven, you've got the big Snickers bar, you know. You got some Cheetos, you know, maybe a thing of ice cream. But you don't think about it losing weight. But there was an interesting study published, I don't know, maybe a month ago, looking at that, and it actually had a significant effect. We don't know, but it's interesting. So what I would suggest you do if you're interested in any of this is just go onto Google Scholar and set up a few searches. Set up medical cannabis, set up marijuana, set up whatever keywords you want, and it'll send you at some interval, you can set that, articles that are getting published. This is what I do. It's like how we learn, and you see some of them are very interesting. Some of them are basic science. They're looking in a lab, which is great. That doesn't speak much to what they're doing in humans right now. So, but anyway, nonetheless, terpenes are the things that give any kind of plant like a smell and a flavor or an aroma. And there's a lot of focus on this. This is a list of terpenes. There are more. Where you see what they're this is a busy slide, but it tells you the effects of each one. They're not necessarily evidence-based. That's like maybe, right? There are some people, if you go and speak, in Pennsylvania, if you walked into a dispensary, we have to have pharmacists in our dispensaries. If you walked into a dispensary and spoke to a pharmacist, you might get some guidance on a few of these terpenes for particular things. And that is mostly based on anecdotal evidence and what they have been hearing. There's probably something there, like myrcene is thought to be good for pain, and a couple of them are thought to be good for anxiety. And we're relying on, right now, patient experience largely to inform kind of the recommendations that are getting made. So very briefly, the reason why cannabinoids work for people is because we have an endogenous endocannabinoid system. We have a system in our body of receptors that can respond to the molecules in cannabis. And some of them are in our central nervous system, and some of them are throughout our periphery. This is why when I rub some hemp cream on my knee that has a meniscus problem every night, I think it feels better because there are receptors there that can respond to that. It also feels better if I rub like an NSAID cream, like diclofenac on it, but there is something there. This is unlike an opioid, which really works through your central nervous system. The endocannabinoid system is through your body. It's also in your organs, which explains possibly why this could be helpful for things like autoimmune conditions, irritable bowel and Crohn's and other conditions, which we have certainly seen people getting some benefits. So we did, this is kind of interesting. Any questions? Let me just, yeah. No, sorry.
Sorry. When you travel, you have to be very careful because even if it's legal in the state you're departing from, but let's say, like I was traveling to Europe. So in New York, I was fine. And I was saying, I bring it, and I also bring my prescription with me from the doctor. So it proves besides the license. Right. But then once I stepped down in Europe, it was illegal. So then when I looked up on the airlines, they said to bring your prescription with you as well as a license, but you still could be pulled out and searched with the search dogs if they smell it.
So just, we'll get that one. That comes up again, another big question. Generally, do not take pot out of the country. Don't. It's like you can in some places, but it's just a bad idea. In our country, if you're going to bring something on with you, put it in your carry-on, take it with you. The one thing you do not want to do is you don't want to pack a vape pen in your check-on bag because it is a lithium-ion battery. That is what they will find. Dogs in our country, airport dogs, don't sniff pot. They sniff explosives, and so they will not find pot. And honestly, TSA couldn't be bothered at all. I laugh. I go to Chicago a few times a year for meetings and stuff, and I come back, and in the airport right before security, there are these cannabis amnesty boxes. They look like mailboxes for people to, like, if you want to throw your cannabis out at the last moment so you don't take it through security, because in Illinois it's legal and medical, it's adult use and medical. And I was with a colleague a few weeks ago, and I said to her, no one has ever used one of those boxes. They just haven't, because TSA doesn't, they really don't care. Now, that said, I probably won't go to Idaho or Wyoming with that. But I'm not giving you legal advice. Do what you will. Most places, a lot of places, be decriminalized. If you land in Philadelphia with pot and they're unhappy with you, they'll charge you $25. So anyway, so we got a grant during the pandemic that was kind of interesting, and it was with a bunch of other big cancer centers. They're small here, but with like Memorial Sloan Kettering and Moffitt and some West Coast ones and Minnesota, Mayo, and we looked at asked all kinds of questions about cannabis, mainly kind of how people are getting their information about this. And this is one of the biggest problems. Virtually no one is getting information from like trained medical people. And that's because there aren't trained medical people. There's no cannabis curriculum content in any medical school curricula. Maybe now a little bit, but not so much. So no one is the number one, and a dispensary worker. Has anybody been in a dispensary before? Yeah, a lot of you. So dispensary worker, 25-year-old, very pleasant, stoned, kind of telling you what they like. Very pleasant though, lovely, good people, just, yeah, okay. The one I went to was a bud tender. Bud tender, right, exactly, a bud tender, right. So you're going to take medical advice from like a bartender, like, right. Not maligning them at all, but like getting guidance on this is one of the biggest challenges, which is kind of what we see one of our missions being. This is kind of what people are using. Most people don't know what they're using, 77%. And still 40% are getting it from a friend or family. I will share these. Smoking and eating. There are, if you've been in dispensaries in like places that have been doing this a while, like Colorado and California, they're like Whole Foods-like establishments of food products. San Luis Obispo has one of the best dispensaries I have ever seen. It was like a Whole Foods. They had 7 kinds of butter. If you want goat milk butter infused with cannabinoids, you can get it there. I don't know why you'd want that, but anyway, it's yes.
I'm just adding a note, your app has all of the slides of all of the presentations, so no shame to taking photos, but you do not need to worry about
feel
it.
free.
It's in your app.
And I'll give you my email. Like I'm saying some of this a little tongue-in-cheek because it just lends itself to that, but also, I'm kind of throwing a whole bunch of stuff at the wall, and this is kind of what we know right now. So about 30%, numbers are up to about 40% of patients who are getting cancer treatment are using cannabis of some sort, mainly for pain, sleep, mood. Those are the 3 things that people mention the most. Side effects are down at the bottom, a little sleepiness, difficulty concentrating, dizziness. All right, so let's talk a little bit about why we are kind of where we are. It is very hard to do cannabis research in this country because of the legal status of cannabis. You can do it, you can get a Schedule I permit from the FDA, and the government will actually supply you with cannabis. There is at University of Mississippi, they grow marijuana, and for federal research purposes. The strain that they grow has about 5% THC in it, which really doesn't mirror what is available widely. There are a couple of other places in the country now from which you can get you can get research grade marijuana. It's very difficult to do this, and most people don't kind of bother with it. And for people who put in these FDA permits, when this gets kind of legalized sometime this year, they're going to kick themselves for having spent all that time. But Anyway, most of the studies that are done are observational, they're surveys, they're focus groups. It's really hard to do a randomized controlled trial, which is the gold standard of medical research, where you have a prospective trial, meaning you're looking forward, you're taking 2 or 3 groups, and you're randomizing patients to intervention arms. So cannabis, like THC, CBD, something else, pharmaceuticals, some combination of them, and then you're getting measures along the way, and you're powering the study, meaning you're getting enough patients in this study that you're able to say at the end of that whether the results that you have observed are significant, statistically significant or not. That really does not happen. There are countries that do cannabis research, just not the US. So Israel, Uruguay, some other European countries have a long history of doing cannabis research. We have just not gotten there. Netherlands, Canada. And so here's where our evidence is. And this is like a kind of a moving target. Pain. There is evidence for pain. There is good evidence for pain. Neuropathic pain, there's decent evidence. So pain, nerve pain in your fingers and toes, it helps. It also seems to help reduce opioid use in people who have pain. So if you're using opioids for pain and you add cannabis to it, there is a decent chance that you may be able to reduce your opioid use. Cannabis is never going to take the place of opioids for intractable pain. It's not. I've seen 2 patients in the past 7 years for whom that has been true. The amount that they had to use would have killed a horse. They were fine, but they were able to stop significant doses of opioids and use cannabis. That is not common. Although, interesting research, Colorado and a couple of other places, they looked at Medicare Part D claims, which are drug claims. Those are prescription drugs. And in Colorado, and this has been in other states, in states with legal cannabis, the claims for opioids in Medicare have gone down significantly. Can't conclude anything from that, just interesting, right? We can't say anything that this causes that, but that's a public health study. You're looking at a big population, you're looking at some insurance claims, and like, okay, so cannabis is widely available in Colorado. It was a significant decrease in opioid prescriptions, like wild. 40%? Yeah, I don't quote me, but it was more than 20%. It was pretty sizable. Chemotherapy-induced nausea and vomiting is a home run, that it works. ASCO, the American Society of Clinical Oncology, came out with cannabinoid guidelines about a month ago, and the only area where they endorse cannabis at this point, they took a very conservative approach, which is totally appropriate, is chemotherapy-induced nausea and vomiting. It works for that. It doesn't get rid of anticipatory nausea and vomiting, if anybody has experienced that, where you get sick before you even get there, but it does help with that. It's interesting, everybody says cannabis makes them high, or hungry, and it does, it may. It doesn't really make you gain weight, although people will test, but there's no good research that says it does. It can make food taste better for people, which is one of the reasons people like it. And it can reduce weight loss. But there are no good options out there for stimulating appetite that are really safe, and so it's a reasonable thing. It's not helping chemo brain. We don't know how. Maybe at some point, but it doesn't worsen it, it seems, but it doesn't make it better. Somebody did a study on that. It was interesting. So jury's out on anxiety and depression. There is no evidence for depression. We have very good treatments for depression. This is not one of them. And so I would stay away from that. Anxiety is different. People get a lot of benefit. When we ask patients when they come for a one-year follow-up, like, what helped you? And what did the cannabis help with? And many of them will say anxiety. And so the data actually points to CBD as being more beneficial for anxiety than THC, but Not so sure. Certainly CBD can help, but like people are using a whole variety of things, so we don't really know. Insomnia, again, not a lot of evidence on that, but people use it frequently for insomnia, and I will tell you that I believe that that is helpful for insomnia. There are some good studies out of Australia on that as well. So this is the kind of the rub here. There are some animal studies, there's some lab studies that show that cannabis or cannabinoids may be helpful as anti-cancer agents. There are no human studies that show that. So this is not for treating cancer. At this point, we do not know enough to say that it is a good idea to stop evidence-based standard of care and use cannabis. And unfortunately, we've seen a couple of people do that, and the outcomes have not been good. But who knows? The lab stuff is interesting. There is some anti-tumor activity in some things. There are some benefits. There are also some drawbacks. So we need to understand that better. Risk is really low. So cannabis is not that dangerous, in relatively speaking. The graph on the left, the more important one, the pink line, these are poisoning deaths from various drugs. The top one being opioids, that blue line that goes all the way up. The pink line on the bottom, underneath the blue line that says Tylenol, that's cannabis. That's how many deaths there are. Okay? Right. I mean, people may feel paranoid, they may feel bad, yeah. Yeah, go ahead.
I don't know if you can answer either of these because they're more anecdotal, but I've been trying to use it for sleep because I've had insomnia since thyroidectomy.
Can you speak up a little bit?
I've had insomnia since thyroidectomy and oophorectomy, so that's
Yeah.
primarily why I've been trying to use them. Plus, it's everywhere in Colorado. So, but I get a hangover when I take most of them, and I don't know what that's from. And the other thing I've noticed too is my coordination the next day is not great.
Yeah.
Like I drop things.
Yeah.
To the point where I like got smoothie on my ceiling, and that
Yeah.
really sucked.
Yeah.
But
Yeah, for sure. And I don't know how much this is one of the things, like experimented, because if you're buying something specifically for sleep, we don't know the side effects of all of these things. And not everybody describes feeling kind of uncoordinated or confused the next day or hungover. Most people don't describe feeling hungover, but there are compounds here that take longer to metabolize and can make you hungover.
I also supposedly am upside down in terms of my reactions. So
Yeah.
indica makes me hyper, and sativa makes me sleepy.
Yeah. Yeah.
So I think that's part of it.
I mean, it's worth playing around a bit. The sleep thing, the CBD evidence is very compelling. People just don't take enough of it. But getting very good quality, full spectrum CBD is interesting. If you are using things with THC, you're buying high CBN things, you may want to kind of take a look at that. Yes.
Have you had any patients that have experimented or used Rick Simpson? Is it Rick Simpson?
RSO?
Yeah.
Yeah. Rick Simpson oil, do people know what Rick Simpson oil is? It looks like pond scum. It's this thick, blackish, oily compound that has all of the materials from the plant. So they're extracting all of the materials, all the different compounds, and it is in a kind of a gel or I don't know, like a goo, and you take very little bits of it. We usually stay away. We do have patients who use it. We stay away from it because most of our patients are fairly novice users, and the amount of THC in it is like having to take a quarter of a grain of rice is like a hard instruction. Nothing against it, though. For the folks who use it, they swear by it. It's expensive, too.
Along the lines of the Rick Simpson oil question, is that good for a person undergoing cancer right now, like treatment, chemo?
For actual anti-cancer, anti-tumor
Yeah.
effect.
Or
So-
what other strains would you recommend for someone who's going through cancer?
So the strains are, first of all, we don't recommend cannabinoids to fight cancer. Like we don't have enough evidence to suggest that. And strains, we focus more on the THC and CBD content than we do on actual strains. First of all, indica and sativa, if people are familiar with those two distinctions. Indica is thought to make you kind of sleepier, and sativa is thought to be more kind of activating. Everything, and then there's hybrid. Almost everything's a hybrid right now. Like everything has been genetically modified and bred and changed so much that those are not really meaningful distinctions. The more meaningful distinction is how much THC and how much CBD is in something, and do you want something that's predominantly THC, or CBD balance, like a 1-to-1? That is more useful. We may have a great color wheel at some point that tells you kind of what to do. Like this compound is good, like this strain has a lot of this compound, go for that. We're not there yet. It is the problem with this is there's a lot of trial and error and it's costly. But we don't focus a lot on strains. There's certainly people who like certain strains. The other challenge with getting wedded to one strain or one type of product is that these are plants, right? And plants go through growth cycles and then they make the products. And in order to, if they run out, they have to grow that again and they make the products. And so, and each grow of a certain strain, even if it's genetically the same, may have different amounts of things in it because it had more light or more water, more fertilizer, or just the moon phase. Who knows? Some states grow inside, some grow outside. There are all these other variables, so getting locked into one thing that works perfectly is challenging. And I've seen that happen over and over again, where folks are like kind of driving all over creation to find the one thing that they feel was helpful. So risks, like don't drive high, don't do it. If you smoke a lot, like more than 20 times a month, nothing wrong with that, but there is something called cannabis hyperemesis syndrome where you can get vomiting from that, just intractable vomiting. It's awful. It's not life-threatening, but this is why people end up in emergency rooms. Some short-term cognitive impairment. Cannabis use disorder, it's talked about a lot. Like, basically, when you're anybody over 25 to 28, the likelihood that you're going to become dependent on cannabis is extremely low. Cannabis is not good for people under that age. It generally, the risks are higher. And so we don't want teenagers, I know they do, and I know I did, but like we don't want teenagers doing that. There are risks. The risks of addiction are greater. There is a definite connection between cannabis use and serious mental illness, namely schizophrenia. We don't know the exact relationship, but they are connected. And so heavy cannabis use can create irreversible psychosis in some groups. Now, these may be people who are genetically predisposed to it, but it's not entirely that. And it's not a lot of people, but it is a meaningful connection, and there's a fair amount of research out there. Labeling inaccuracies. This is fascinating, right? So even in Pennsylvania, we have a medical state, we don't have adult use. You can buy two products that are THC and CBD compounds, say a liquid that you put in your mouth. One can say 10-to-1 ratio, and the other one could say, 10-to-1 ratio. And one of the brands labels it THC first, then CBD, and the other one labels it CBD first, and then THC. So standardization, you need to pay attention to that. It has gotten a little bit better, but this is not pharmaceutical. It is not as precise as that, so we kind of realize that pretty quickly. The other thing with any products you're buying in dispensaries is the boxes are labeled. The product usually is not, and so keep the box or take a picture of it. Because we say to patients, bring in what you're using, and they bring in like 5 vape cartridges and 4 white bottles, and we're like, We have no idea what this is. We made that mistake early on. We're like, this is not helpful. Keep the box, bring the box in, we can help you sort that out. There's also not even in medical states, you go to see your doctor enters a prescription into the electronic health record, it gets filled, the doctor is able to see that that prescription was made, that it was filled, and that it is due for a refill, things like that. We certify somebody for cannabis, that goes into the vapor. There is no feedback loop in that. So it is dependent on you to let people know what it is. This is just again, you can have the slides. This is just how the different preparations and kind of where to start with them, how long it takes to work. Usually inhalation is the fastest. We tell people, if you can, don't smoke the flower, don't smoke the actual leaf. It's just a bad idea. It has all kinds of fungi on it, and just don't burn things and suck them into your lungs. Unless, there are some people who are real romantics and they like that. Better if you need to inhale something to vaporize it. Vaporizing is a safer way to go. It still is an irritant, but you're not going to get a fungal infection from it if your immune system is suppressed. It works fast. So for nausea, vaporization is really helpful. Right? You don't want to wait an hour and a half for something that you've ingested to work to relieve your nausea. So quick onset or appetite is good for that. The field's evolving. There are products. The problem is that THC molecule is pretty big, and so breaking it down is not such an easy task for your body. And so there are preparations now that are breaking this down, making it smaller, making the onset faster, which seem promising. There are also inhalers, meter dose inhalers, like an asthma inhaler, that has a fast onset that is safer as well. You'll see these kind of popping up. Yeah.
Does it depend on your metabolism? Because I will take something and it won't kick in until 4 hours.
Yeah. Right. So the question is, does ingesting something depend on your metabolism? It depends on a few different things. It depends on when you ingest something, it's getting metabolized through your liver. With edible cannabis, it is anywhere between an hour and a half and hours. And so that is not that 4 hours is long, but not uncommon. Generally taking it with food. With food, not on an empty stomach. You say that one more time?
I watched Lord of the Rings with my friend, and then it kicked in.
Afterwards, right, exactly. Which is all right. You have to just start a few hours earlier. Yeah. Yes.
Yeah. Oh, and you definitely get a
Oh,
different
sorry.
effect if you do it with, you need to eat first, because then the high comes sooner and faster. And I was getting a chest tattoo for the mastectomy, and I took it like you did for the Lord of the Rings. It did not kick in during the whole,
Yeah.
when she was drilling into my chest, but afterwards it kicked in, and then I needed someone to drive me home because
Yes. This is the problem with edibles. Yeah. And please, the edibles are great. It just you just need to not take more in that while you're waiting. Yeah.
Hi, so I have two questions and a comment. The first question is, have there been any studies or do you have any anecdotal information for THC or CBD and menopause?
Yeah.
And then second question is there any concern with needing to think about how the plants were tended? I know there's inside grow, outside grow. Is there, chemical, defoliants, pesticides, et cetera? And then my comment is, I live in Oregon, so please come and visit us. There is a lot of really great information, and I just wanted to say one of the bits of information I've been exposed to is there's a really great store in Portland called Shebop that's basically a sex store, and they sell all of the accessories and things that you would like to know, but they did a really wonderful, very, very educational class about THC and CBD with pain with intercourse and libido. So for anybody who is going through perimenopause, menopause, issues with that, I believe they offer that course online, and I found it really, really beneficial. And it's primarily about using topicals that are CBD and THC, which a lot of people find very effective.
Yeah.
So really high quality education, high quality information, and it's called Shebop. I'm happy to talk with people after that, but really useful.
Great questions. So, and comments, and thank you, because this is another one of those areas where we get asked all the time about this. So there are topical preparations. We are doing a small pilot project with a preparation called Vela from a company, Vela Bioscience, which you can find commercially. It is a topical vaginal cream that is CBD based that you put on 20 minutes prior to sex, and it's supposed to enhance one's ability to have an orgasm. It's not a lubricant per se. You don't do it internally. The results have been really interesting. There's something there, but in this process, we've been speaking with the company that developed that is now looking at other topical preparations. Ingested stuff, we don't know, or smoked stuff, we don't know. It relaxes people, so that may help. But the topical seems to be where the work is being done right now. Certainly is being paid attention to. I was on a call with a scientist from some very impressive institution who is this is his life's mission to kind of research this and understand the biology of it. But certainly, and I'll look up the one. Oregon does a good job with all of this stuff. Yeah. I was at a conference there last year. I spent half the time talking to various dispensaries and educating myself, but I was largely impressed. They've been doing it a while.
Any thoughts on menopause studies or quality safety of plants?
So quality safety. So anything that you're buying, generally speaking, anything that you're buying from a licensed dispensary in that state has been tested twice for known contaminants, fungi, other pollutants, and for the composition, so which compounds are in it and what percentages. You are safe with that. Anything that is bought elsewhere, I have no idea. But that question comes up a lot, and you can look it up. Each state kind of publishes kind of what they're analyzing, and they look at all heavy metals and other toxins that are in water and fertilizers. And so we're comfortable saying that things that are bought through state dispensaries are safe with regards to kind of additives and other things. They grown inside or outside, certainly fertilizers are used, but they look at a fair amount of detail on that. We asked our Pennsylvania state, we participate in an initiative with Pennsylvania and have asked that question that has come from our patients, and I felt reassured by that. Yeah.
Is there any nicotine in products that you can get at the dispensary?
Not that I'm aware of.
Because I'm going into construction and,
Yeah, not that I'm aware of. No. Doesn't naturally occur in that. Go ahead.
Hi, 2 questions. First one, very quickly. As a psychologist, I have a 13-year-old patient who is dying to do marijuana, and I'm wondering what the lowest age healthfully, obviously legally under 21, no, right?
Yeah, legally, yeah. You could rest on that, but really there's no good guidance for kids using.
Even medically? Okay.
No. Listen, it's a cost benefit, right? All of this is a cost benefit. If a child is going through awful chemotherapy and has intractable nausea and vomiting, and the only thing that helps them is cannabis.
Right.
Right? But for a typically developing non-ill child, you'd be hard-pressed to find somebody who's saying that's okay.
Got it. Thank you.
I hate to be so forceful about that, but this is one of the things that we do know.
I actually agree. I just wanted to be able to
Yeah.
report back to
Absolutely.
the boy
Yep.
how bad it is. Okay.
Yeah.
Second, in terms of CBD or THC and sleep, I have found that the THC, both of them actually increase my heart rate. Any thoughts as to what product to use to help sleep but not elevate the
I
heart
don't.
rate.
They both increase your heart rate. Are there other additives in any of these products? It depends where you're getting them, and it depends. Like there are some terpenes and other cannabinoids that can be activating like that. I would look carefully into kind of what it is that you're buying, and because we just don't know that, and we don't have enough evidence on a lot of these things. But the THCV that I was talking about before is an activating cannabinoid. It for some people it like does make them race. So I don't know what you're buying, but that's a tough one. And I've heard that before as well. It can definitely increase heart rate, but yeah.
So I have a daughter, she's 22. She has Crohn's disease and BRCA1 positive, has not had cancer. She is in grad school. She takes Vyvanse and Adderall. And she uses THC, and she gets, whenever she gets something, it's typically from a dispensary. Her issue is joint pain. It's almost like rheumatoid arthritis, and her issues don't seem to be GI. She doesn't have a lot of GI symptoms. She has more joint pain symptoms.
From the Crohn's?
From Crohn's, yeah.
Interesting.
So is that how CBD or THC or the combination? What's your recommendation?
It certainly could help with that. Certainly, I would definitely get something with higher CBD, lower THC. But because you have all these receptors in your joints, so we've seen a lot of people who've gotten benefit from that. But I would definitely go higher CBD, like a 10-to-1 CBD to THC. It's a plant, right? So the more you pull it apart, the less you're going to get all those things working together. So isolating a compound may be beneficial for something, we just don't know. This is why, has anybody ever taken Marinol, Dronabinol, the pharmaceutical synthetic THC? So there's a pharmaceutical drug called Marinol. It is just delta-9 THC. You ingest, it's a pill, and almost nobody likes it. And the reason they don't like it is it's just THC. It makes them groggy. It may help their appetite a bit, but it just makes them groggy. It's lacking all the other compounds that exist in that plant. And so there is some argument to be made to have some of everything in there, like maybe in different proportions. But when you start splitting things out, you may be losing some of the benefit. It's called the entourage effect, which is, you've got a plant with, 200 or 300 compounds in it, and we don't know what really most of them do. And the magic might be in having them all together there in some way, rather than saying, okay, delta-9 THC is the answer. And that didn't work with Marinol. People don't really like it. Most people who've tried it will go, if they have access to medical cannabis, will go and do that instead. Let me just move. We got a few minutes left here. The title said CBD and melatonin, so I educated myself a little bit here. I know about CBD, but as we've mentioned, CBD is no abuse potential. It's available everywhere. The 1, 2, 3, 4, 5, the sixth line down where it says FDA, this is the most important thing about CBD. You could get CBD where you want, but you want to make sure it's a dietary supplement. So you want to make sure that good manufacturing processes have been used, and these are the label. You want to look for a certificate of analysis where it tells you what's in it, GMP, which is a stamp, good manufacturing processes, NSF and USP. These are all things you look for on any nutraceutical, on any supplement that you buy in like the Vitamin Shop or Whole Foods or wherever you go. If that's on there, you're good. And you can get it in a variety of different forms. But you just want to make sure you're getting what you say you're getting. And there's decent evidence for anxiety, insomnia. Seizures has very compelling evidence. Pediatric pain. The most interesting stuff more recently is using it to manage withdrawal in substance use issues. Not a lot of evidence, but it's safe and it's being studied kind of at present. And just a little language here. When you see CBD, if you're getting it from a good place, I don't have any financial connection to any of this, but CBD MD is a decent site. It is owned by the people who started Charlotte's Web. If anybody knows what Charlotte's Web is a strain of marijuana of cannabis that is all CBD, and it was very helpful for seizures. Sanjay Gupta did a wonderful piece on CNN years ago. It's pretty, and so they've commercialized stuff, but they have a company. It's like traded on the stock exchange. It's a legit company, and they make very good CBD products. And so you're going to see these words occurring: full spectrum and broad spectrum. Full spectrum. The only difference is full spectrum has THC in it. Not usually high amounts because it's hemp-based. It has small amounts of THC, but they don't take the THC out. Broad spectrum has everything but the THC. And then you can get like an isolate of just CBD. Again, if I were going to do this, I would get broad spectrum. Just because there are all these other things in there that may be helpful, right? Costs are, it's expensive, but it's not outrageous. That's all relative, of course. Yeah.
I actually struggle from epilepsy, so I've
Yep.
never heard about CBD helping with seizures. Is there a specific type, like lotion? Like again, I'm just trying to learn more.
Yeah,
of
no,
that.
it's so you certainly could do a little internet research on that. The CBD is what is helpful for seizures, and there is a drug, Epidiolex, which is the only plant-based pharmaceutical drug in our country, FDA approved in our country right now. It's made for a pediatric seizure condition called Dravet syndrome, and it's a liquid. I don't know that adults can get, it's very expensive, but it is pure CBD, so there is no THC in it.
Interesting. Thank you.
Yep. Let me just do this slide and then I'll hear your question. So melatonin, who has taken melatonin here before? Yeah, a lot of people. Does it help? Yeah. That's what the evidence says, right? For the people it helps, right? But I know. So live and learn, right? And so I know it's a hormone. It has something to do with sleep-wakeful cycles, and we have less of it as we get old. Welcome to getting old. And so you could take it. Some people like the spray. This is the bottom one is the biggest issue. It's like you don't know what you're getting. Like minus 83% to a plus 438%. There are many studies out there that show that like you have no idea what is in that bottle. And so I don't know of good brands personally. I'm sure that's researchable, but that feels like something big. So here's the evidence. But the bottom line is if it's not helping you, it's not helping you. There is interesting for jet lag and shift work disorder for folks who have that. And it does seem to lessen the time it takes to fall asleep. But I think you need to make sure that you're taking what it says you're taking before you start. It's certainly not harmful, but it's money. Yeah.
Arthritis was suffering horribly from insomnia,
yeah.
like down to 2 hours a night
Yep.
of sleep. Very low dose, might be slightly positive. Anything above that actually created night terrors.
Wow.
And I mean intense.
Yeah.
Okay.
Point taken, for sure. Like, any of these things you don't know. And for the vast majority, they're probably fine, but certainly who wants night terrors? And finding the dosing sweet spot where you have something that has anywhere between minus 83 and plus 400 and whatever is not such an easy thing to do, but that, of course. This by no means is gospel. I'm like, certainly people are have outlying experiences. I think if something is working for you, great. We definitely know people for whom melatonin works great. I know a lot more for whom it does not work, I would say. Yeah.
I was interested about the menopausal studies like this lady had asked about earlier. There is a good company, Foria, F-O-R-I-A, and they have the suppositories.
Yeah.
You just, stick it up there, and it helps because it's like a desert after the medical menopause down there. So it does help, and that's a company that's legit.
Yeah.
So they have it, the suppositories for that, and they also have like an Awaken Intimacy oil that also helps for the sexual health piece.
Yeah, it's a good. I think it has hyaluronic acid in it as well. Yeah, which there's a whole movement, and it's fantastic because hormone-based therapies, we know that need to be very careful with that. But it's also the Wild West of nutraceuticals, so just kind of reputable brands that are sold in reputable places that are manufactured well. There are a number of hyaluronic acid suppositories as well that are helpful. And there was if people look back, it was even last year, maybe last year or the year before at this conference, we did a panel on symptom management. And I am terrible, I'm blanking on her name, but there was a psychologist she was Mass General or Dana-Farber, one of the Harvard institutions, who works in women's sexuality post-cancer, and spoke fairly extensively on her experience with kind of what is out there and what's available. It may be worth looking that up. I can find the name if you want to email me, but she was like fascinating.
It's available on our Force YouTube.
It is, yeah.
Yeah. So.
First person I heard who like kind of that is her, main area of focus. It was it's a question that comes up 5 times a day. Yeah.
Yeah, there's a session after this about sexuality.
Sexuality, yeah.
I have a question about melatonin. If you take melatonin regularly, is it true that your body doesn't produce it as much? And then that's the myth, and I didn't know if that was true. I know that it stops being effective.
It does, but it slows down that axis, that pituitary, I forget the exact axis that it works on, but it rebounds when you stop it. Unlike steroids, which really kind of can shut down your adrenal pituitary axis, and it takes a long time for that to kind of normalize. My understanding is that it will impact it, but it will, when you stop, it will return.
Briefly, I saw the slide that represented the various terpenes.
Terpenes, yeah.
That had allegedly beneficial. Specifically, I'm looking for gastric relief. Is there any recommendation, or I think you just passed it.
Yeah, so this isn't the slide I would necessarily use for that. I just passed by it, right?
That one.
Yeah. Let me connect with you afterwards. People have had various experiences with that. So CBG is often the cannabinoid CBG, not necessarily a terpene, but CBG is often felt to be very helpful for GI stuff.
Gotcha.
Which is widely available and kind of easy to find. It's a major cannabinoid. Anybody else? I'm gonna you take when you get the slides, take a look. I didn't go over these, but it's kind of cool stuff. Labeling really matters on this stuff. You have to pay attention to things like how much is in what. Like on the top left is a tincture that has 1,000 milligrams of THC in something this big. So a dropper of that is going to be, 35, 40 milligrams of THC. On the bottom, a dropper of that is going to be 3 milligrams. We had an 85-year-old patient who was sold the wrong one and was like getting chemotherapy and was way too high. It was very sad. She's fine, but it was a very uncomfortable experience, and there's really nothing to turn that off. Once that happens, you can give high amounts of CBD, and that'll stop it a little bit. But hospitals don't have high amounts of CBD laying around, so we had to just keep her down, turn the lights down, play some music, get her a snack. Just be careful. You don't want to overshoot. You're not going to die. Cannabis is dangerous to little children and pets. Keep them away from little children and pets. Ingesting a lot of it. Don't do that. Anyway, thank you, everybody. I appreciate your time today and your great questions.